we're going to go ahead and get started, committee, and today we're going to hear a presentation on the Midwest Stem Cell Therapy Center, and I will introduce Dr. Prentice for an introduction to our guests that will explain to us.
Thank you, Madam Chair. Dr. David Prentice. I'm the chair of the advisory board for the Midwest Stem Cell Therapy Center.
The mic on, Doctor?
Not. How's that? Can you hear me now? Thank you, Madam Chair. Dr. David Prentice. I'm chair of... We'll get it right after a while.
We'll get there.
There you go. All right. Chair of the advisory board for the Midwest Stem Cell Therapy Center. What you're going to hear today is an annual report from the Midwest Stem Cell Therapy Center. Just by way of a little bit of introduction, the legislature put this into effect in 2013. It was a legislature-driven initiative. And in fact, Madam Chair knows, but maybe some of the newer members of the committee don't, she actually held a joint committee meeting, an informational meeting, the year before that in 2012 to introduce this idea that Kansas needed a stem cell center, an adult stem cell center, to actually develop and treat patients with adult stem cells. There was nothing like this in this entire region of the states before then. So every year since then, according to statute, we come to give a report on what the center has been doing this past year. That report will be given by Dr. Sunil Abhyankar, who's the director of the center. You should have a copy of his slides, and Dave will also make available a copy of the text of the annual report for you afterwards. I'm going to let Dr. Abhyankar go ahead and make the presentation. You can see on that first slide he's got a long list of credentials. He is a very well credentialed doctor. The reason he's talking remotely today, he's on ward, and so he's taken some time off to come talk to you remotely, but then once he's done with the presentation, he needs to get back to the patients, and I will be here to answer questions.
Are you with us, Doctor?
Can you hear me?
There, we've got you. Yes, thank you. Welcome.
Right. Okay. Hi. Hello there. Good afternoon, and thank you for having me present today, Mr. Chairman and members of the Health and Human Services Committee. It's my pleasure to present the activities of the Midwest Stem Cell Therapy Center for the last year. And I prepared some slides. And do you want me to share the screen or my screen?
Yes, that'd be fine. Thank you.
Okay. And what you see behind me in this virtual background is the actual part of the lab, which was helped, founded by the help of the funding from the state. You can see a biosafety cabinet or a hood. And then this piece of equipment in the back over here is one of the bioreactors that we have that is used to manufacture some of the cells. So I'm going to share my slides now. And hopefully this works smoothly. Can you see my slides?
Yes, we can.
Okay, alrighty. So as Dr. Prentice mentioned, the Midwest Stem Cell Therapy Center was set here at KU to facilitate adult stem cell research and therapy on a global level. And it was done in 2013. The legislature passed the establishment, and it was in 2016 that actually the GMP lab, the GMP stands for Good Manufacturing Practices Lab, began functioning and producing cells that we can use for cellular therapy. When the center was started, it was headed by one of our prior directors, Dr. Don, and I am leading this center since 2018. And the objectives that were set forth by the legislature for us were pretty straightforward. They're listed here in this slide: to facilitate the delivery of adult cord blood and related stem cell therapies in the Kansas City and Midwest regions, in the hospitals where appropriate, inform the public by doing educational sessions and seminars about different options, create a web page that has a list of stem cell therapies, and foster a regional network of physicians that are trained and participate in research on adult stem cell therapies, and to serve as a core facility to manufacture these cells. And we have accomplished many of the kind of guidance from the state, and we have accomplished almost all of these points. And lastly, to initiate clinical trials, which is kind of the ultimate reason why we are here, to help treat patients in our area with these cells. So this is the structure, the organizational structure. We are based at KU Medical Center, and I report to Dr. Salate as well as Dr. Simari. We have an advisory board that is active, and we meet every quarter to update them on the activities of the center. We also have a scientific advisory committee that is mostly comprised of researchers at KU, but also at K-State, and a couple of other institutions that we meet every 4 months and guide and come up with new ideas and new projects that we can take on. Dr. Soder has been here since the founding of this MSCTC and the GMP lab. She's a GMP facilities manager, and helping her is quality assurance and quality control staff. We have production assistants. There are 2 positions here. One just recently left, so we have a vacancy over there. And this MSCTC collaborates with entities locally. We collaborate with, obviously with other research at KU Medical Center, but also at K-State and at Children's Mercy Hospital as well. And our main focus has been collaboration with the Cancer Center currently at KU with the bone marrow transplant. I'm a part of the bone marrow transplant department at KU. These are our current advisory board members. David has been gracious enough to be the chairman of the board for the past many years, and he's done a fantastic job guiding us. And Dr. Salate and Senator Mike Thompson, who has also been really fantastic. Dr. Bleka, James Shirley, Jeff Wright from KU, Dr. Robinson, Mrs. Ruth Collier, Dr. Sun, Representative Dan Hawkins, Greg Lakin, Scott Weir, who's at KU and IME, and then Senator Mary Pilcher Cook is now off the board, but she is with a keen interest in the Cell Therapy Center. She still attends some of our board meetings. This is the current staff that we have, and as I was mentioning earlier, the scientific advisory committee that we established. So just a pictorial view of what the GMP lab is. So we are housed in this lead building, and on this floor, on the first floor, is where our research laboratory space is. But in the basement is where we have our GMP labs space. There's the entrance and the gowning area, and we have 2 clean suites, and room 1 and room 2. They have incubators, centrifuges, biosafety cabinets, or hoods, as we call them. And then the second room has these fancy bioreactors. And there's another bioreactor that was donated by one of our bone marrow transplant patients, which is housed in the new room that we constructed, new area just adjacent to this whole area that was constructed in the past year. Now, our center focuses mainly on mesenchymal stem cells that we obtain from umbilical cord, from fat and placenta and the cord tissue. There are many other sources of these adult stem cells, including most commonly used bone marrow, like for bone marrow transplantation and other uses, and then heart, brain, teeth, pancreas, liver, muscle, and skin. But our focus has been mainly on these 3 areas of obtaining these stem cells. We have a lot of projects in pipeline and also ongoing clinical trials, and I just wanted to highlight, give you a big 10,000-foot view of all the research activities that are going on. In the preclinical proof of concept, we have collaboration with the University of Alabama using these cells to help repair lungs in animals, ferrets actually, that have bronchitis. And here we collaborate with Dr. Salazin here at University of Kansas Medical Center. Dr. Nuro has been doing research with these cells on traumatic brain injury in mice, and Dr. Jingxi Wong in cartilage repair, and there's some exciting news there. And Dr. Hartmut Jeski has been doing liver repair, Tylenol toxicity, and liver repair by these mesenchymal stem cells. We have some preclinical effort that may go into the clinic in a few years, and this is mainly in the area of ALS research or Lou Gehrig's disease, as well as CAR T-cell therapy. And then finally, the ongoing clinical work that we have accomplished so far. We've completed a phase 1 acute graft versus host disease project where we enrolled 10 patients on this study, and we gave these Wharton jelly mesenchymal cells to these very sick patients in the hospital. And this is continuing to a phase 1b and a phase 2 study. We're also doing a gamma delta T cell study. We are going to harvest mesenchymal cells from the abdominal fat of patients who have inflammatory muscle disorders, and this study is just getting started. We have ongoing studies in collaboration with pharma companies in Crohn's disease, stroke repair, and also in bradykinesia with an organization called IMAC Corporation. So the Wharton jelly is made up of this jelly-like substance in the umbilical cord, and the cords are donated by women who are giving birth, a C-section at KU Medical Center. So informed consent is obtained, and these cords are brought to the lab, and these cells are dissected out from the cord and then grown. It's a laborious process, and it's highlighted over here in this graphic manner, where once we get the cord and the cord cells are isolated in a petri dish, then they get placed in flasks where they grow, and then further bigger plastic flasks called hyperstacks. Because these cells grow in contact, they don't just float in the media. The red is the media. They grow in contact with the plastic surfaces. So it takes a lot of surface area to grow these cells. And it takes about 2.5 months from the beginning to the end. And we start around 10-15 million cells from the cord and end up with up to 2 billion cells at the end. And these cells are then kept in small batches and frozen in liquid nitrogen. And then they're ready for use. So we use these in the graft versus host disease, which is a major complication after a bone marrow transplant, where patients can develop this rash and diarrhea, and it's a very poor prognosis, especially if this becomes refractory to prednisone. And so we did a 10-patient phase 1 study. We got approval from the FDA to do the study. And we use these cells that came in this bag, that is the picture shown over here on the right-hand side. Before the cells can be given, they have to pass many criteria of safety, and there's no contamination. They have to be pure and viable. So they have to pass all these quality control procedures before the cells are released and infused into a patient. So it's a very scrutinized and supervised process. And this is our publication related to those 10 patients. This was published a couple of years ago in 2020. And you can see this is the overall survival in these 10 patients now going on for more than 3 years now. 50% of those patients are alive. We would have expected only about 15 to 20 of these percent of these patients to be alive. So giving these cells to these patients, very sick patients, did help their graft versus host disease. So we have now submitted a grant to the FDA and NIH to do a phase 2 study that's going to involve 6 other institutions. So KU GMP lab will manufacture the cells, and once we have a patient in 6 of these bone marrow transplant institutions across the country, there's Ohio State, there is a program in Arizona, and then Alabama, Nebraska, KU, and Salt Lake City. These cells will be given weekly. The cells are manufactured here, they'll be frozen, and then by courier, they'll be sent over to their treating center to be infused into the patient. So we applied for this grant in October. We hope to hear about it in May, whether we make the cut to get funding from the FDA and the NIH. Another important thing that is ongoing in the lab, as I showed you earlier, these cells grow in these fast and it takes a lot of space. Is there any way to make that more efficient? And Dr. Soder has been doing that very diligently and working hard to come up with a 3D method. So 3D method involves the use of microcarriers, the small particles, to which these cells adhere. And now they can float, but they actually adhere to the small molecule or small particle rather, and they completely cover the particle and coat the particle after they grow, as seen in this photograph over here. So the cells initially expand in the flask, and then from there they have to be placed in this bioreactor. And we are in the process of validating 2-3 different bioreactors from 2-3 different vendors. And the problem is that this pandemic has created a supply chain issue that you all have read about and all of us have read about. And because of that, there's a big backlog of getting all these devices and instruments. So we've been waiting for a year now to get this in our lab. And once we get this, it is going to significantly improve our efficiency in manufacturing these cells. So this is how it looks on a microscope. These are the microcarriers, and they are polymers, and the cells adhere to them. And this is like on day 1 when you put the cells in the microcarrier, and sorry, day 3, and then by day 6 you can see, you can't see the carrier. The cells have multiplied and completely adhered to form a glob around that particle, and they keep growing over here in adherent fashion. And by doing that, we save space, and we also save how much media we need. It is a much more cost beneficial aspect. This particular bioreactor that we have in the lab is actually used to manufacture CAR T cells, and we are in the process of collaborating on a clinical trial with the NIH. This will be a phase 1 clinical trial developing a very novel CAR T that has 3 particular targets on its surface to go after cancer cells in patients with lymphoma. So this is going to, it's going to take about a year to come to fruition because there are a lot of regulatory steps and practice manufacturing we'll have to do on this particular bioreactor before we say we're ready to inject into patients. And then, another important study that is going on is again in leukemia, where we are creating this vaccine in the patient to give the patient after they receive the chemotherapy, and the hope is that it improves the long-term survival. This is from a phase 1 results. Here we are collaborating with the Beth Israel Medical Center in Boston to do this. So those are the clinical kind of endeavors that we are undertaking. In addition, we have many R&D and preclinical lab work that is going on, which I mentioned, some of it which I mentioned earlier during the talk. Another important duty, so to speak, of the MSCTC is to host education sessions. And prior to the pandemic and during the pandemic, we did virtual education sessions. We did a virtual talk in Hayes, we did a virtual talk in Salina, in addition to having an annual conference. And this was the annual conference that we held in 2020. It had to be virtual, of course, and it was a fairly good attendance. I think there are 185, if I'm not mistaken, attendees who were, these photographs are from the conference 2 years prior to that, where Governor Collier was attending. And we are planning our next conference on September 16, 2022. Not knowing what's happening with the pandemic, we still decided to keep it virtual, and we can send the link to everybody at the legislature who is interested. It's a very good conference, and excellent speakers from all over the country that are going to focus on adult stem cells in regenerative medicine and other applications. So the next few slides talk about what is our funding situation look like. And the MSCTC receives the bulk of its funding from the state of Kansas annual appropriation. We also have some donor giving routed through KU endowment. That's how we got this bioreactor, which cost us about $250,000. There is also an advisory board and a KUEA fund. Income from our GMP manufacturing. So we have manufactured dental pulp manufacturing. We have manufactured the gamma delta T cells. We also collaborated with IMAC Regeneration, and they did a phase 1 study, and they gave us manufacturing costs for that particular trial. And my income from clinical trials and stem cell banking that I mentioned earlier. So this is a snapshot of our financial report fiscal year 2022. Total income that is received from the state is 751,363, and this is the pie diagram, the breakdown of the expenses, salary, research supplies, equipment validation. The annual conference, the live conference was costing us about $50,000-$60,000. Changing to virtual has saved us a lot of money. Insurance to cover all the equipment that we have. Media, which is media is not the social media, but media is media used for culturing all these cells. This media is very expensive because it has to be GMP grade, it has to be extremely sterile, and has to be ultimately infusing into humans, so it has to meet all those criteria. So this is the breakdown of our expenses. And the next slide, which you have in your handouts also, is the little bit more projected expense for the remaining of fiscal year 2022, as well as the actual expense that has already occurred, and then some income that is we expect for that we had in the last year, and some that we expect later this year, in this coming year. The pandemic did put a dent on the number of clinical trials that we could do. There was a slowdown everywhere, all over the country, and so some of that reflected on the manufacturing and enrollment on the clinical studies. So thank you for allowing me to give this presentation, and we thank the members and the legislature for the support to the center. We are treating patients in the Kansas City and Kansas area and locally. We have established a reputation as a place to be for GMP manufacturing. And thank you again for all that you do for us. I'll be happy to take any questions.
Representative Epley.
Thank you, Madam Chair. Thank you for that up-to-date presentation, and whoever answers either one's fine. Chimeric antigen receptors, can you give a little more depth on information on what those are? So I think some of the committee members have some basic knowledge, but not everybody does, and I think it'd be, the CAR T cells are really important to your work. So comment about that, and I've got two other quick ones.
Sure,
Madam Chair,
thank you.
Go ahead, Sunil.
Sorry, no, go ahead, David. Go ahead, please go ahead.
Madam Chair, Representative Epley, the CAR T, the chimeric antigen receptor, the idea there is you actually develop a way to target immune cells back to attack someone's cancer. So you literally will take some immune cells from the patient and you engineer them in the lab so that they have part of that receptor that will target the patient's cancer, another part of the receptor that essentially turns on to a high degree the killing ability of these cells. So you have to take those cells from the patient. You find the ones that are already essentially directed against your particular cancer. It's a personalized type of medicine, very targeted. You develop this hybrid, this chimeric receptor, so it will target the cancer and turn on this killing ability, high killing ability of the cells. Grow up a bunch of those in the lab, which is what they're doing in the Kansas Stem Cell Center, and then you give those back to the patient. And it's been very successful over a number of years, both at the Kansas Center as well as in the larger scientific community.
Any specific malignancies that it's better for?
They've started primarily, sorry, Madam Chair, Representative Epley, they've started primarily with lymphomas, leukemias, other kinds of blood cancers, but that's expanding rapidly into lots of different solid tumors. So it's got a great future, and again, a great way to directly target to a patient's own cancer and get rid of it.
Madam Chair, if I may, just the GMP manufacturing, what does GMP stand for?
Madam Chair, Representative Epley, good manufacturing practice.
Oh.
This is sort of the highest level. And clinical grade is what you want to think of.
So it's like best practices then?
Yes, it is.
Madam Chair, last question. What this ALS trial I'm really fascinated with, are you recruiting patients now? Are you in phase 2 on that, or do you know what phase you're in on that, on the ALS study?
Let me defer to Neil. Do you know?
Yeah, Epley. This is still in a preclinical stage, so it is not yet. Yeah.
Okay, thank you, Madam Chair.
Representative Wolfmore.
Thank you, Madam Chair. And actually, Dr. Epley asked my questions. I have heard, the CAR T is fascinating to me. I've heard Dr. Joel McGurk talk about it and all his great work, so I was going to ask you more about that. And then also, I was also going to ask about the ALS, Lou Gehrig's. So are you hoping, is it more for a treatment or some kind of cure, or can you tell me a little more about that?
Yes, indeed. Madam Chair, Representative Wolfmore, and I might note that Dr. McGurk was on the advisory board during its inception for several years, rotated off, and is spending a lot more time with the patients, but we really appreciate it, have his insight. The ALS, the idea there is it's a treatment. It seems like a lot of the effects and a lot of the cause of the destruction of neurons in ALS comes from inflammation. The fancy term, mesenchymal stem cells, MSC, from the solid part of the cord have a unique ability to quiet down inflammation, essentially to stop what's called a cytokine storm. So, and they've used that to good effect already in the clinical trial for graft versus host disease. That's where you get a mismatch in a bone marrow or stem cell transplant, and that transplant, the graft, actually starts to attack you, the patient, the host. It turns out a lot of the tissue damage in effect is because that transplanted immune system goes into overdrive in what's called a cytokine storm. Cytokines are simply signals to stimulate the immune system, but this is way overkill. It's essentially a scorched earth type of thing. Those MSC from the solid part of the umbilical cord, what's called Wharton's jelly, actually calm that storm. They saw it in this graft versus host disease trial. They are looking at it in a number of other conditions, and that's what they plan to do with the ALS.
If I may add to that, sorry, if I may add to that, David, thank you. The other, besides suppressing inflammation, these cells also secrete growth factors that help grow the connections of the neurons. So there are two things that are going on in this. Sorry, thank you, David.
So as those neurons are dying, this creates more connections. Fascinating.
Yes.
It preserves them and then also stimulates them to start regrowth, yes.
You know, it's time for something to be, my father died of ALS 44 years ago, and there seems to have been no progress at all. And so this is wonderful news to hear. Thank you.
Exactly so. We're glad to see this come up.
Representative Clifford.
Thank you, Madam Chair. Was there not an ask recently to do a COVID trial with the mesenchymal cells? Maybe that I read so much scientific literature, maybe it's elsewhere, but it's specifically for the cytokine storm. It was not a KU, as far as you know, Dr. Prentice?
Madam Chair, Representative Clifford, the short answer is yes. Because it's that same cytokine storm that causes for the most severe cases of COVID-19. Patients that are down in that well and you're putting them on the respirator and so on, and there's nothing available at this point. The idea is to take those mesenchymal stem cells and calm that storm and be able to pull those patients back out of that well. And there's a proposal to do an initial phase 1 clinical trial, 10 patients, basically using those same cells.
Two questions. One would be, are not nanoparticles possible delivery vehicles? I know the cells are being grown up on polymers, but can they not be targeted using nanoparticles?
Madam Chair, Representative Clifford, they could be. You still need some cellular components to be able to target them, whether it's the receptors or whether it's the whole cell itself on one of those particles. The beads that they're growing these cells on are bigger. These are micro particles rather than the smaller nanoparticles. You could use that. The other possibility, and one which is under a preclinical study at the Kansas Stem Cell Center, is using what are called exosomes. These are essentially little blebs out from one of these cells, but they're secreted and they contain various growth and cytokine factors, and they can also have those little targeting molecules on their surface. So there are more than one way to skin that cat.
And final question, those of us who grew up a little older in medicine dealt with, solid organ transplant, and then CMV and Epstein-Barr were always a problem. By going with cord blood and this Wharton's jelly, or I know we were testing for purity and viruses and things, but is that sort of free because the placental barrier, is it free of those types of viruses? So when you transplant, you're not giving the patient problems? Thank you.
Madam Chair, Representative Clifford, you're exactly right. They still might, and so that's why they do all of those tests to make sure these are completely uncontaminated and clean. But you have a more naive system with the cord and the cord blood, so you're right that it gives you a cleaner system in which to do this. And then, again, you've got these extra properties that these solid part of the cord, the MSC, seem to possess.
Thank you, Dr. Prentice. Thank you, Madam Chair.
Representative Blacks.
Thank you, Madam Chair. Thank you for your report. From the time you take the cells out of the body, what is the timeline? How long does it take you to train them to be assassins?
Good one. So, Neil, do you have the...
Yeah. Yes, thank you for that question. So I'll just pull this CAR-T cartoon over here on the CAR-T trial, CAR-T that is going to start in about a year. So the time of manufacture for this is about 10 days. So the cells are collected from the patient's blood and then purified, the lymphocytes are purified, and they get infected with this viral vector that inserts the gene of the protein in the cell, and the cells then are expanded in this bioreactor. So that process takes about 8 to 10 days to manufacture the cells that can then be infused, and they go after the targets for which we have engineered them to go after the target. Now, the Wharton jelly, on the other hand, when we manufacture this takes about 2.5 months. So this is a slower process, and that's because these cells of the Wharton's the cord, they adhere to surfaces, and that's why it takes us that long here.
Thank you. Thank you, Madam Chair.
Thank you.
All right, committee, further questions? Representative Berquist.
Yes, just one. Thank you, sir, for being here. Thank you, Madam Chair. Just one question about the CAR-T cells. Are they only the best for this process? And I've known people that went to Houston for successful procedures. Are they only from the individual themselves and then back to themselves? Is that the best way to do it?
Madam Chair, Representative, go ahead, Sunil.
No, go ahead, David. Okay, I'll answer that then. Madam Chair, Representative Berkowitz, so it's a very good question, actually, because when we harvest the cells from a patient who has already received a lot of chemotherapy, there is something called cell exhaustion. Many of the cells that we isolate they have lost their killing capability from all the exposure to chemotherapy, and so they may not sometimes be as effective. So that is why we actually have clinical trials ongoing where if these cells are obtained from healthy donors, and with the technology called CRISPR, they remove some of the HLA antigens from the cell so that they don't react against the patient, because these are from a third person. So that is also ongoing at KU. Now, we are not, the project that we have that will start in a year, the cells will be obtained from the patient for that.
Thank you, sir, and thank you. Thank you, Madam Chair.
Committee, further questions? All right, seeing none, thank you very much for being here, both of you, and appreciate the update on the stem cell. It's pretty exciting where we started and where we're at today, so thank you.
Thank you,
Thank
Madam
you.
Chair.
Excited too. Thank you very much. Bye-bye.
All right, next committee, we've got a presentation on a Kansas statewide survey attitudes towards vaccine, and I have Tracy Russell, Executive Director of the Nurture KC. Welcome to committee.
Thank you so much, Madam Chair and members of the committee. My name is Tracy Russell. I serve as the Executive Director of Nurture KC, which is a nonprofit serving pregnant women in Kansas City, trying to improve rates of infant mortality. Am I not?
Did you bring us some written?
I do. We have it right here.
Okay,
Sorry about that.
sorry. Okay, go ahead, you're fine.
Okay. Serving to drive down infant mortality rates as well as maternal mortality rates. The second program that we have at Nurture KC is called the Mid-America Immunization Coalition, and it is that program that I'm here to speak to today. In January of this year, we decided to commission a poll around routine childhood vaccination. You know, as the issue of vaccination becomes more and more of a hot topic and a political one at that, we wanted to really get kind of a baseline of what Kansans' attitudes are towards vaccination. It has been our belief that the silent majority is quite supportive of that routine schedule, but we didn't have the data and the evidence to back that up. So that's really what drove this work. And we do have some slides that I'll be presenting here, but we used public opinion strategies to conduct the survey. They are based in DC, and our primary researchers were Glenn Bolger and Jarrett Lewis. Jarrett is actually available virtually today, so should there be any questions around the methodology or results, he's happy to take those. Some of you may be familiar with Glenn. He is a 3-time Republican Pollster of the Year nationally. He has several Kansas ties. He's done polling for some of our current and former U.S. senators in the state. So as I said, this is very current. It was in the field from January 27th to February 3rd of this year. 600 registered voters were surveyed. That includes 312 who were reached by a landline phone, and then 288 who completed an online survey. It has a margin of error of plus or minus 4%. We can go to the next one, please. Thank you. So here's the demographics of the respondents. You know, we wanted to make sure that we were truly representative of the population at large here. So to that end, 52% of those surveyed were women, 48% men, and we compiled it based on several age categories. And really, our intent behind that was we wanted to gauge if there were differences of opinion based on age. We also looked at this from a political affiliation perspective. So 43% of those who responded identify as Republican, 25% lean independent, and 28% identify as Democrat. And then we also have a lot of diversity in terms of education levels as well. We looked at primarily 3 media markets, and I'm going to explain that in a little bit more detail here momentarily, but those were Kansas City, Topeka, and Wichita markets. Next slide, please. So what we ended up with is 32% of respondents live in urban areas, 35% live in suburban areas, and then 33% are in rural areas of the state. And as you can see by the chart below, that there's remarkable consistency in terms of support based on geography across the state. Next slide, please. So at the top level, we just wanted to gauge sentiment for kind of the principle of vaccination and whether there's support for that across Kansas. What we found was 95% of respondents indicated that they believe the childhood wellness vaccines are a good thing. And in fact, that percentage ranked just above even going for an annual checkup in terms of the importance of it to good health, vaccination. Next slide, please. And this crosses all partisan lines. You can see from the graph up here that there is incredible consistency, and at a time when I think there can be a lot of polarization on any given issue, this we found truly remarkable, that you're, in the mid to high 90s virtually across the board here. Next slide, please. And then we also looked at that from an age perspective to see if we would find differences in levels of support. And what we found again was remarkable consistency. The lowest that we found was the age group of 45 to 54, and that was just a percentage lower at 93%. Next slide, please. So we wanted to drill down on this issue. So we've now established that most believe vaccines are a good thing in general, but there have been a lot of questions raised around both the safety and the efficacy of vaccines. So we wanted to test on that as well. And as you can see, again, we're in past the 90 percentile in those who believe they are both safe as well as effective. So from there, once we had a general viewpoint on just feelings around vaccination, we wanted to look at how Kansans feel about current policy around vaccination, what is current state law. And so we asked regarding support for the current requirements that children be vaccinated to attend child care centers as well as K-12 schools. And what we found is that 91% support those requirements as they exist today. And again, pretty remarkable number. Next slide, please. Oh, you've got it. Thank you. You're ahead of me. People felt so strongly about it that they even indicated they would be more likely to support a candidate who supports the current vaccine law in the state. And 2/3, 67%, indicated they would be more likely, which is 25% indicating it would make no difference. So the next issue that we asked about concerns existing exemptions. There's been, a lot of talk around broadening exemptions to perhaps include a philosophical objection. And so we wanted to ask about that, but we also wanted to ask about the existing religious exemption just to get a feel for where Kansans are at. And what we found is, in principle, 56%, a majority, support having a religious exemption to vaccines. What we did, though, was we went a little deeper with that to say, okay, do you support it in its current form, or are you more supportive of some restrictions on that religious exemption, similar to what we see for the medical exemption currently? And what we found was that, again, a 2/3 majority, 65%, believe both parents should be required to consent to the religious exemption. Current law requires one parent. 64% believe that religious exemptions should be subject to an annual review, as medical exemptions are, and 61% believe religious exemptions should require documentation from a religious leader. You know, with the medical exemption, it requires a physician. So I think that was pretty enlightening for us to see, you know, where people are on that issue. Then we asked whether they supported increasing the number of exemptions, so broadening what we currently have. 67% indicated they would not support adding to the exemption allowances. 64% indicated that they would not support the addition of a philosophical exemption to the schedule. So again, pretty resounding opinion around that. And then next we wanted to ask about authority for implementing the vaccine schedule. And we can go to the next slide, please. As there's been a lot of talk around who should have jurisdiction over this, who is the best entity for this. And currently, of course, that authority resides with KDHE. We found 85% believe KDHE is the appropriate entity to oversee that vaccine policy. And 73% would not like that moved into the legislature. And particularly with the 65 and over group, they most strongly felt that they believed that moving it into the political body would unnecessarily politicize the vaccine schedule going forward. And what people really responded to in terms of messaging was that they want those who work on these issues every day in this field, who have that expertise, to be the authority on it. So those are kind of the top line remarks. And I just wanted to conclude, and these are in the pollster's words and not mine, but he stated, "It could be easy in this moment to think divisions over COVID-19 vaccines may lead to divisions over wellness vaccine policies. But Kansas voters are clear. They support wellness vaccines, requirements around them to attend schools, and leaving the authority of setting wellness vaccine policy to the State Department of Health." With that, I would take any questions, as well as we do have the pollster available. Thank you, Madam Chair.
All right, Representative Epley?
Thank you very much, Madam Chair. And just to be forthright in the light of day, none of these questions related to the current COVID-19 vaccinations, correct? This is all about the childhood vaccinations and adolescent vaccines that are basically for children, right?
Madam Chair, Representative Epley, yes, this was to the childhood vaccination schedule. And it was really our feeling that, you know, some of these initiatives we've seen around creating broader exemptions and such began before COVID. And so that was really what we wanted to measure, was the underlying support.
Thank you.
Representative Blex?
Thank you, Madam Chair. Thank you for this report. And Representative Epley asked one of the questions I had, but when we define, how are you defining wellness? I mean, did you give any kind of explanation on that in the survey?
Madam Chair, Representative, yes, we did. We listed out many of the wellness vaccinations, so pertussis, mumps, polio, meningitis, so that they were aware of what we were talking about. And we clearly stated that this survey was not on COVID vaccination.
Okay, I thank you for that. And I think that is important, because in my mind, if I was to look at my emails, I would say this survey is totally 180 off based on my emails of people actually opposing things. But I do think that that's a lot due to COVID. And, you know, here you're dealing with things that are time proven and people know they work. and it's not an experimental thing. And so, but I do, quite frankly, at least in my district, I do receive a lot of emails from parents that do not want to see an additional vaccine for a variety of reasons, in their mind at least. And they feel like, you know, parental authority and whatever in order to, you know, comply with school regulations is something. So I do appreciate you doing this. And I know from surveys that in the past I've conducted, it all depends on how you ask a question, you know, because sometimes that's an important on there. And you said statewide, how wide was that across the entire 105 counties, or at least some representation from all parts of the state?
Madam Chair, Representative, yes, we do have crosstabs that show how many by county.
Okay. I thank you for that. Thank you, Madam Chair.
Representative Kelly?
Thank you, Madam Chair, and very interesting report. A question that has come to my mind as I get these same emails as Representative Black's is that, do you think any of it has anything to do that with people that aren't as tenured in life as I am, that don't remember kids in their class with polio, or don't remember shutting down schools because of mumps or measles or whatever? And so if it's not happening, it's not a problem. And you think some of that goes back to it's in their lifetime it hasn't been the case. So, but in my lifetime it was. So,
Madam Chair, Representative Kelly, I think there's a lot of truth in what you're saying. We're almost the victims of our own success at this point in terms of not experiencing a lot of these deadly diseases any longer. And that's why I was so curious about the age breakdown, although, as you can see, there was still a lot of consistency. And I will say, one of the questions, the messages that we asked on, just to gauge how compelling respondents viewed it, was we asked about how important was polio in terms of vaccines, and that still pulled number one as the most compelling reason for that routine schedule. It's still polio. One of the issues that I would like to do a deeper dive into going forward is we also had asked if everyone knew of someone who had opted not to have their children vaccinated, and 25% indicated that they did know of someone. And looking at kind of the demographics of that, it's much higher, like in your 35 to 44 age range. So I think going forward, these are the things we need to explore and be prepared for.
Representative Clifford.
Thank you, Madam Chair. Madam Chair may not be aware, we had a very lively discussion in Rural Caucus today after this presentation, and as you sense, there was skepticism among some of our colleagues. I wonder if your pollster could address, you know, what you were hearing from people was your survey was biased. You know, you asked about wellness vaccines, not sickness vaccines, or, you know, some verbiage, but I wonder if your pollster could address some of those issues that came up so we can communicate to our colleagues that this is really how people feel. Thank you.
Madam Chair, Jarrett, are you on?
I am. Can you hear me?
Yes.
So what was the question, Representative Clifford? It was, I wasn't privy to that discussion that took place earlier.
Yeah, some recency bias in the survey that you're educating your respondents to respond favorably by whatever means, or saying it's a wellness vaccine gives it a positive spin. Just how do you address bias?
Yeah, it's a great question, Representative. I would tell you that one of I think the very first question we asked in the survey was just a very plain, straightforward, and Tracy covered this early on, that said, I'm going to read you some statements about health. After listening to each statement, please tell me how important it is to you to maintain good health. And the three things that we gave were taking vaccines for diseases like measles, mumps, and polio, going to the doctor for an annual checkup, and taking an annual preventative vaccine like the flu vaccine. And the measles, mumps, polio vaccine, there was no language about wellness. that was injected into that. Now, the wellness vaccine, we did use that language to try to differentiate from COVID because we deeply understand how charged COVID is right now and the COVID vaccine, particularly with children. So that to me was the neutral kind of point where Tracy made this point earlier, but the taking vaccines for diseases like measles, mumps, and polio actually outranked going to the doctor for an annual checkup. 95% of the Kansans respondents said that it was either extremely important. It is either extremely important or very important to maintaining good health.
Follow up. Yeah, and Jared may not know, but across from our state capitol is the statue of Samuel Crumrine, who really was the father of public health in the United States. So it's hard to be here trying to reverse 70 years of public health improvement. I mean, I've lived in countries and done mission work, seeing people, blind from measles, scarred from chickenpox, or sterile. And all kinds of other untoward results. Just a question for you, Tracy. I'm not sure, Sarah's not here now, but what is the issue of the uptake, or maybe Dr. Epley could tell us, the lack of uptake of the HPV vaccine? Because as a man, if I could take a vaccine that prevent prostate cancer, I'd be first in line. And here we have a vaccine that can prevent a cancer in women, and yet there's a struggle on uptake. So I'll defer. Thank you.
Madam Chair, Representative, I'm not sure that I could answer that. I can tell you anecdotally, I have 2 teenage boys and they've had theirs. I don't know. I think there are probably several factors. I think one would be that's a newer vaccine. And I think for parents, they've had some misgivings on that one. And I know we have KDHE here as well. They might speak to it better than I can.
Representative Epley, or should I say Dr. Epley?
Thank you, Madam Chair. It's really all about optics, and just as a point of education, we've discussed this in the past through the organization that I work with, but it is required, as I know of, in 2 states in the United States now for adolescent vaccinations, but it's the optic of being a sexually transmitted disease that is what keeps folks from getting it. And when it was rolled out, there were some issues, whether initially it was a 3-vaccine series, now it's steadfastly a 2-vaccine series, which is pretty good. And what people fail to realize, because they get caught up again in the optics, is that it's over 94% effective for preventing cervical cancer. It's one of the most effective vaccinations we have. But because of the optics and the age at which people get it, as young as 10 or 11 and the second shot by age 15, it does, I think, dissuade some parents from allowing their child to get it. And fortunately for some women, then as they grow into adulthood, they can get it later in life. And it's been expanded in its indication to go up to, I think, age 35 now, I believe. But again, KDH is here, HE is here. They may have some other thoughts on it, but I really think it's the optics of the transmissibility of it, and that's really hard to overcome. And, to their wisdom, KDHE has never considered requiring that vaccination. Just like, with all due respect, I'm not trying to speak for them, I think it'll be never or a long, long time before we'll ever hear anything about COVID vaccines being required for any age group in the state of Kansas. But they may want to respond on their own. They're here, so Madam Chair, I'll defer to you. Thank you.
Did you want to, or it's up to you? Because we're not trying to put you on the spot, but tell us who you are and welcome.
Thank you, Madam Chair. I'm Phil Griffin. I'm the Bureau Director for Disease Control and Prevention at KDHE, which is where immunizations is housed. Dr. Epley really capsulized it pretty well. CDC has admitted very vocally that they made a mistake when HPV vaccine was first rolled out because they didn't talk cancer at all. They only spoke about preventing a disease associated with a sexually transmitted disease. And so that was the upfront message that went out for the first couple of years, actually, that the vaccine was out there. And they have been backpedaling ever since then and trying to correct it, have funded quite a few projects and trying to change that message. And we've been involved with that. And we have seen a steady increase in those that are receiving the vaccine. Again, it's kind of a messaging thing. It's, the further we get away from that message of it being sexually transmitted and more people are hearing the cancer message, it's kind of like polio. People don't recognize or hear that anymore. So the parents that are there now are hearing more of a cancer message than a sexually transmitted disease message, and some more are receiving it. And we've got a lot more evidence now as well with people who have successfully not gotten HPV cancers as a result of, and people are getting those stories. So it's improving. It's certainly not where we want it to be. We are no longer at the bottom. Kansas for many years was at the very bottom of the national rates for HPV, and we're closer into the middle now, lower end, but still moving up. But it really is about the original messaging of it.
Thank you.
Well, and I had actually forgotten about that because I was chairing hearings on that vaccine when it first came out, and that's exactly the debate that was going on. So, Representative Berquist? Oh, did you have another question, Representative? I'm
No,
sorry.
that was an interesting discussion. Thank you, Madam Chair.
Okay. Representative Berquist?
Thank you, Madam Chair. And this question be, I think, for Mr. Lewis. Are you available?
Yes, sir.
Thank you very much for this extensive report, specifically targeting wellness vaccine requirements. And I'd just like to ask you, as a polling organization, have you been involved in doing similar polling directly towards the COVID vaccine to a general population?
Yes, I have. Our firm has, and I do a lot of healthcare work, Representative Berquist, and so yes, I have.
Is that something you could give us a general outlay of how that worked out, or is that appropriate for this time?
Can you give me, well, yeah.
How the results turned out? Was it dissimilar to this, or the same, as far as percentages of approval or favor?
It's different. It's definitely, there's far less support for for COVID-19 vaccine. And that's why we were intentional in the language, and Tracy referred to this, but in the language in the survey that we used, or that we wrote, we were very clear to make sure that we were differentiating from the COVID-19 vaccine, because we've seen a lot of data from adults of all ages, from parents that are not that are hesitant or reluctant on the COVID-19 vaccine.
Thank you, sir. And I could just ask if you could make any of that survey data available to our chair. Maybe we could receive that as well. That would be helpful.
Absolutely.
Thank you.
All right, Representative Wolfmore?
Thank you, Madam Chair, and thank you to the Chair and Vice Chair. Two excellent topics today, very helpful. And this one is particularly timely because some of the bills we're seeing and some of the discussions that are going on, so really appreciate it. And, you know, someone else said something similar. You know, you get 50 emails about something and, you know, you think it's a groundswell back in your community, but I think what this is showing us is that the very silent majority thinks very differently. So this is extremely helpful, and I appreciate it. Thank you.
Further questions, comments? Oh, Representative Turner and then Representative Kelly.
Thank you, Madam Chair. I guess I'll contrast to those comments because I've heard the pollster just say that, you know, they were clear to differentiate to the folks that were taking the poll that this is not COVID. But I don't see that anywhere on this presentation, and I didn't know it until other questions were asked here. So it seems to blur vaccinations into a lump, and it only was after questions were asked that it was clear that this is not COVID specific, because all the conversation I've heard, the emails I've gotten, have all been specific to the topic of the day, which has been COVID in recent times. So it doesn't surprise me, now that I know the context, I think people have a high confidence and a high level, and I'm not surprised by these results in those pre-COVID traditional vaccine kind of responses. Makes sense to me, but it wasn't clear until it was asked questions and clarified, and to have a banner here to clarify that exact thing would add a whole lot more, because this was left on my desk in the chamber. and I never knew. I certainly thought somebody was trying to tell me, oh, you look at this. This is what people think about COVID and everything else, and it's not COVID and everything else. So anyway, a little more disclosure would have helped. Thank you.
Representative Epley.
Well, I guess, Madam Chair, thank you very much. I'll give a really quick response. When you pass these things out in the chamber, you make a quick explanation. And I thought clearly explained that, but obviously I did not, and I apologize for that. But I did try to contrast at the time I presented in the chamber, but I must not have. So again, for all clarity's sake, this is nothing reflecting on the COVID-19 vaccine. This is all about the required childhood wellness schedule. Thank you.
Representative Kelly.
Thank you, Madam Chair. And this is for the pollster. There was a question asked about, did you do one on COVID? Have your firm ever done a survey on the flip side of it for the thought about childhood vaccinations only? From, where the survey was for people wanting to know how many thought they were right.
Representative Kelly, I'm not sure I followed that question. I was with you for a minute. I think I lost.
What I'm thinking, is there a survey on the flip side of this that would say, how many of you think people are wrong that there should be childhood vaccinations? And maybe this survey does that, but just wondering, somehow the thought has to come out for a group to form and grow so much that there is something out there that says, yeah, we're behind you. You're right. We don't need these vaccinations. And whether the results on this poll are the negative side, that those 7 or 10% are all there are that's making all the rumble, or whether there's actually more there. And if you haven't done it, or you don't even know of one, that's fine. But I just was wondering, somehow there has to be something that makes that movement grow, it seems to me.
I can't speak to, we have done work on childhood vaccinations before in our firm's history. We're a 30-year-old firm. We've pulled for a significant amount of projects over the course of 30 years. I have not been here all 30 years. I'm a little bit younger than that, but I can't speak to a specific poll that shows the other side. I would say in our world, as you all probably recognize and understand, it's the side of the intensities that drives action. And in our world, it's the strongly supports, the much more favorables, much less favorables. And so when there are a lot of times it's that those groups who show intensity in a survey that will kind of push for a movement, push for something. The data in this survey was very clear, and the question language, going back to the comment a couple comments ago about it not showing, it's in the script that our interviewers read. It's half of the survey was done online, half of the survey was done over the phone. It was very clearly distinguished from the COVID-19 vaccine to make sure that respondents knew. But the data was pretty. I mean, you saw the numbers, a few moments ago as Tracy walked through the data. It's pretty strongly in support of these vaccines, the MMR vaccine and the many other vaccines that children go through as they progress through toddler and grow older. So I can't speak to where the groundswell is coming from, but this was, we do a lot of surveys, we do a lot of polling. You don't see numbers like this very often.
Okay, Representative Epley and then Representative Turner.
Thank you, Madam Chair. Again, just for the timeline on this, the COVID vaccine has not even been out hardly 2 years. And so it was experimental for the first almost 9 months and became approved in, I think, August, September of 21. And so, correction, I get my years mixed up, of 20. And so I think it's going to be a long time before, I think, or ever. The analogy I use, I think this is very much going to be like the flu vaccination, and I'm not aware that flu vaccines are required for anybody except healthcare workers in certain situations, and that's up to those healthcare organizations. But I don't think we're ever going to see COVID vaccines required, except, the Supreme Court's spoken on this. They said it will be required for people receiving CMS monies. And so those of us in healthcare who deal with those at risk and those that are sick probably should be vaccinated and will be vaccinated, or will have an exemption, a religious exemption or a medical exemption. So I think we're looking at apples and oranges here. Today we wanted to present childhood vaccinations, required vaccinations that have been around for decades. I mean decades. And we can't get lost in the weeds over COVID-19 vaccinations, because I don't see that they're going to be required by anybody from a government entity in any state or any municipality in the near future. Now, that's not to say it won't be so in California or New York. I can't speak to that, but certainly in the Midwest, I just don't see that happening, especially after what we've been through in our society. So I don't know, Dr. Clifford, do you have any comments?
Yes, thank you for the floor. I think what we're seeing, though, and it's a point of policy, you know, when we had the special session in November, I was willing to vote to give, you know, consenting, aware adults a philosophical objection. But we're seeing, and some of it's in our own Senate, folks pivoting to creating that same thing for children. And I think we have a special interest when it comes to children. And as I said in Rural Caucus, you know, if I was a pregnant teacher and I had unvaccinated kids, I'd be petrified to be in that room. So there are special interests when it comes to children. And I think this survey was preemptive to try to head off pivoting from that philosophical objection by consenting adults to it being created for children. And that's where I would draw the line. Thank you, Madam Chair.
Representative Turner.
Thank you for the follow-up question. The pollster had said that it was clear to those that were interviewed that this is a non-COVID. So I'll phrase my earlier comment in toward a question. So as I look through this, because to me this is a report that's a standalone product. If somebody throws it on a desk and somebody else picks it up, they ought to be able to understand what they're seeing. Are the words COVID anywhere in this presentation, or that this doesn't include that? Or am I missing that? Or what page is it on?
Madam Chair, Representative, in my written remarks, I specifically say this does not pertain to COVID. And this is, what I'm showing you today is 13 pages of a 56-page total presentation, just trying to give the highlights. But yes, I apologize for making that clear at the beginning. I think I've presented this about 10 times now, and this is the first time I haven't referred that it did exclude COVID, but it's definitely in my written remarks and in the survey clearly.
Representative Haswood.
Thank you, Madam Chair. I noticed in your demographics there wasn't a racial equity or breakdown. Was there an intended to have racial representation? I just know because like in the Native community, especially in the African American community, there's a lot of vaccine hesitation because of medical trials and researchers unethically have performed on our communities.
Madam Chair, Representative, I will say, we were actually just talking about that today, that we should have done a racial and ethnic breakdown as well. I will say this was about a 17-minute survey, 36 questions, and I have said if we do this elsewhere, we would definitely want to capture that information as well. So thank you for pointing that out.
And I have one more question, if I may, Madam Chair. Excuse my ignorance. Can you help me with the definition of religious exempt? And is there a list of religions that are on some type of list? I feel like religious exemptions and philosophical get mixed a lot, and we've seen that in the past year. I don't know where I can see like a list of specific religions that apply to the religious exemption.
Madam Chair, Representative, there isn't a specific list of religions per se. I know that the general standard is that someone has to demonstrate a sincere belief to qualify for that.
Okay, thank you.
Committee, are there further questions? All right, seeing none, thank you very much for being here, and I want to thank, both of our presenters today. I think it was very good information for us to receive. I get real excited with where I remember when we started with the Stem Cell Research Center and where it's come today, and I think this survey was very timely, so thank you very much for being here.
Thank you so much.
Okay, committee, I think we're on for Monday, correct? Okay, we're adjourned till 1:30 Monday.